In New England, we have some very long, very dark winters, and that seems to affect children and adults in terms of their mental health dramatically. We do see in our emergency department a worsening of depression and anxiety as the seasons change. This is complicated by the fact that many adolescents and children are stressed by school and that the winter months tend to be more stressful than, of course, the summer months. But we do also see a number of changes that happen with children and adolescents in the winter time. During the winter, we see much worsening of depression. Children whose depression may have been able to be controlled with just family support during the summer months, getting much worse during the winter, and children starting to have those severe warning signs of being hopeless, of thinking about hurting themselves, of thinking about just not wanting to be alive. And so seasonal depression and anxiety can get much worse and even life-threatening during the winter. It's something for parents to watch out for. Children tend to sleep longer and have more difficulty getting up in the winter. They tend to eat more if their mood is being affected by the sun. They also tend to have a lower mood and higher anxiety and larger numbers of panic episodes. If you suspect or you've noticed a pattern over the years of your child doing worse in the winter because of, let's say, the light being lower or the weather being poor, it is something to bring up to your primary care doctor or with your mental health professional. Especially if parents are seeing that their children are having dangerous thoughts, maybe are writing about suicide or talking about suicide, or they're noticing on their Facebook page or their Twitter page that it's becoming more dark and more morbid. There is a 24-hour hotline available in Rhode Island, and that is staffed by mental health trained clinicians who can answer the phone any hour of the day, discuss the problem with you, and figure out a good resource to hook up the parents and families with. They can also advise you as to whether or not the emergency department might be a good way to go in that moment.
In this video, I'm going to talk about the biological basis of depression. And I'm not talking about just a passing bad mood, but I'm talking about major depressive disorder. Major depressive disorder is a major cause of distress, disability, and death from suicide. It is the prototype of the category of mental illnesses called the depressive disorders, which involve distress or disability from abnormally negative mood. In addition to negative mood, the depressive disorders often involve related symptoms, such as feelings of hopelessness or loss of enjoyment in activities. As of 2014, when I'm making this video, our understanding of the cause of major depressive disorder is still very limited. When we look at the brains of patients that have major depressive disorder, either with the naked eye or with traditional microscope studies, there are basically no consistent abnormalities that have been seen in the tissues of these patients. However, special scans and research involving animal models have suggested that there are some functional abnormalities that can be detected in the brains of many patients with major depressive disorder. So here in this illustration of the brain, we're looking at the outside of the brain, and the different lobes of the cerebrum, the top part of the brain, have been labeled with different colors. And in this illustration, we're also looking at the brain, but it's been divided into right and left halves, and we're looking at the inside of, in this case, the left half of the brain. And a couple of specific areas that have seemed to have abnormal activity in these studies involve this part of the brain in this light blue color, which is called the frontal lobe. Let me just write that. Frontal lobe, the lobe that's most toward the front of the brain. And over here on the inside, that would be all of this stuff. All of this stuff right here is also the frontal lobe. And the other part can't be seen on the outside, it can only be seen on this inside view. It involves a number of different structures like this structure here, and some others that are behind the brainstem over here that are called the limbic structures. Let me just write that word down, the limbic structures. Limbic structures, right here. And these studies have suggested that there appears to be abnormally decreased activity in areas of the frontal lobe and areas of increased activity in areas of the limbic structures. These findings seem to fit well with other studies showing a role for these parts of the brain in regulation of the emotions, and in particular, responses to stress. Functions of the brain that seem to be particularly abnormal in patients with major depressive disorder. In regards to stress, it's also been noted that many patients with major depressive disorder have abnormal blood concentrations of certain hormones that are particularly associated with stress. For example, the hormone cortisol, that's a major stress hormone. There's a particular area of the brain that controls most hormones, including the stress hormones, that's located right here. And this area is called the hypothalamus. Hypothalamus. And the hypothalamus talks back and forth to many areas of the brain, but two areas in particular that it communicates with back and forth are the frontal lobes and the limbic structures of the brain. So it's thought that perhaps abnormal communication between the frontal lobes and the limbic structures and the hypothalamus in major depressive disorder play a role in why there are these abnormal concentrations of certain hormones related to stress in the bloodstream of these patients. These stress hormones may affect most tissues of the body, but they also affect the brain itself, including the frontal lobes, the limbic structures, and the hypothalamus that actually controls their amounts in the blood in the first place. So for major depressive disorder, it's still unclear which abnormalities of these stress hormones are causes and which are effects of the disease itself. Some features of major depressive disorder also appear to involve abnormalities in neuronal pathways using certain neurotransmitters, the molecules that communicate between neurons in the brain. And the abnormalities of these pathways may cause abnormally decreased or increased activity in certain parts of the brain, like the frontal lobes and the limbic structures. Collections of many of these neurons that produce these neurotransmitters have their somas, or their cell bodies, in a few areas of the brainstem, this structure below the cerebrum, and then their axons project to many areas up in the cerebrum, including the frontal lobes and the limbic structures. One of these pathways start in what are called the raphe nuclei of the brainstem. And there are several groups of raphe nuclei at different levels of the brainstem that send projections up to many areas of the cerebrum, including the limbic structures and the frontal lobe. And they're responsible for much of the serotonin that's secreted in the brain. Serotonin, which appears to be abnormal in many patients with major depressive disorder. Another pathway starts in an area called the locus coeruleus. Which is located right around here in the brainstem, and it also sends long axons up to different areas of the cerebrum and releases a lot of the neurotransmitter called norepinephrine. Norepinephrine. And this also appears to be abnormal in many patients with major depressive disorder. And then there's a pathway that starts with an area called the ventral tegmental area, which I'll just write as VTA for short, which is located around here in the brainstem, and which also sends long axons up to different areas of the cerebrum. And the ventral tegmental area supplies much of the dopamine to the brain. Dopamine. These neurotransmitter systems affect the function in many parts of the brain, including the frontal lobes and the limbic structures, and supporting the idea that abnormalities of these systems are involved in major depressive disorder is the fact that medications that affect these different neurotransmitters, dopamine, norepinephrine, and serotonin, often improve the symptoms of major depressive disorder. A newer idea that is interesting is that there may be abnormalities of what is called neuroplasticity. Neuroplasticity, which is a big word that just means that the brain changes in response to experience. And these changes may occur down at the level of a connection between a couple of brain cells, a couple of neurons in the brain, where the strength or efficiency of information flow from one neuron to the next may change based on experience. Or it may happen at the level of networks of neurons that are widespread, different kinds of connections and pathways that information is flowing through the brain based on the experiences that the brain is having. And evidence is accumulating that aspects of neuroplasticity appear to be abnormal in animal models of major depressive disorder. But like the other abnormalities that have been found so far, it's unclear if these abnormalities of neuroplasticity are a cause or an effect of major depressive disorder. So there have been a number of biological abnormalities found to go along with the mental abnormalities we see in major depressive disorder. Biological And other clues to biological factors that may be involved in the cause of major depressive disorder include genetic studies that suggest that a predisposition can be inherited. Several genes related to brain function have been associated with the risk of developing the disease. It may be that these genetic abnormalities increase the risk of the brain developing abnormal responses to negative or stressful events, particularly early in life when the brain is still rapidly developing in response to experience. But like most, if not all, mental disorders, in addition to the biological factors, there does appear to be psychosocial factors as well. Psychosocial factors. Certain psychosocial factors have been linked to the risk of developing major depressive disorder, such as childhood abuse, stressful events, or limited social support during adverse circumstances. So that it may be, for many, if not most, people with major depressive disorders, as with most other types of mental illness, it seems that an unfortunate constellation of both biological and psychosocial factors combine to cause the illness.
Up to 3% of children and 8% of adolescents in the United States have depression. The condition is significantly more common in boys under the age of 10, but by the age of 16, girls have a greater incidence of depression. Bipolar disorder is more common in adolescents than in younger children, but bipolar disorder in children can be more severe than in adolescents. It may also happen with or be hidden by ADHD, OCD, or CD, attention deficit hyperactivity disorder, obsessive compulsive disorder, or conduct disorder. What causes depression in children? As in adults, depression in children can be caused by any combination of things that relate to physical health, life events, family history, environment, biochemical disturbance, and so forth. Depression is not a passing mood, nor is it a condition that will go away without proper treatment. Children with a family history of depression are also at a higher risk of depression. Children who have parents with depression tend to have their first episode of depression earlier than children whose parents don't have the condition. Children from chaotic or conflicted families or children and teens who abuse substances like alcohol and drugs are also at greater risk of depression. What are some signs and symptoms of depression in children? And they are as follows: crankiness, anger, sadness, hopelessness, social withdrawal, more sensitive to rejection, changes in appetite, changes in sleep patterns, vocal outbursts of crying, trouble concentrating, fatigue and low energy, physical complaints such as headaches, stomach aches that don't respond to treatment, feelings of worthlessness or guilt, impaired thinking or concentration, thoughts of death or suicide. Other risk factors include biomedical factors, psychosocial factors, anxiety disorders, and so forth. Other clinical features of depression: loss of interest, psychomotor agitation, reduction in energy levels, feelings of worthlessness, impaired thinking, social withdrawal, being combative with parents, delinquent behavior. Also, psychotic depression is associated with the apparent loss of reality, delusions, or hallucinations with a depressive and self-critical or self-punitive content are prominent. And of course, your bipolar disorders are occasional elevation in mood status, such as excess energy, lack of judgment, excitability. What makes teenagers vulnerable to suicide? Many teens who attempt or die by suicide have a mental health condition. As a result, they have trouble coping with the stress of being a teen, such as dealing with rejection, failure, breakups, school difficulties, and family turmoil. They may also be unable to see that they can turn their lives around and that suicide is a permanent response, not a solution to a temporary problem. Other risk factors for teen suicide are as follows: having a psychiatric disorder, family history of mood disorder, history of physical or sexual abuse, or exposure to violence or bullying, substance use disorder, access to means such as firearms or medication, exposure to the suicide of a family member or a friend, loss of conflict with close friends or family members, physical and medical issues, being lesbian, gay, bisexual, or any other sexual minority youth, also being adopted. What are some of the warning signs that a teen might be suicidal? Talking or writing about suicide, withdrawing from social contact, having mood swings, increased use of alcohol or drugs, feeling trapped or hopeless, changing their normal routines, doing risky or self-destructive activities and actions, giving away their belongings when there is no logical explanation, and personality changes.
Here's a question that recently came into our counseling department. My daughter told me she is depressed and considering suicide. What should I do? This is a really important question. I'm going to encourage you as a parent to stop and take this very seriously and encourage your child to talk to you. I like to use the statement, "Tell me more about that," so that I can get my child talking and telling me what they mean by that. And as they're talking, I want to listen for some very specific key points. We use the SLAP acrostic. S stands for specific plan. Does my child have a specific plan to harm themselves? If they do, I need to take that seriously. The L stands for lethality. Is their plan something that is going to kill them or not kill them? If it's going to kill them, we need to take that very seriously. And then A stands for availability. Do they have availability to access their plan or access the weapons that are part of their plan? If they do, we're going to take that very seriously. And then the P stands for proximity to people. If your child is isolating and not staying around people, that can put them in danger. So if they're meeting all of those criteria, then that's an immediate need for intervention. We're going to take our child immediately to the emergency room or get them evaluated immediately by a counselor because that's pretty serious. If my child meets one or two of those criteria, then I'm going to stay close to my child. Sometimes by just staying in direct line of sight of them for 48 hours, you can help decrease that depression, and sometimes that suicidal thought will leave on its own. But if it doesn't, then we want to take some specific actions. The first action is get them to express how they're feeling. So if you can get your child to either verbalize how they're feeling with their words, or if they need to journal and write that down, or if they need to do something artistic to express that in an artful way. We call that art journaling. It can be really helpful to get your child to be able to express how they're feeling. The second thing is we want to teach our children how to express and deal with their emotions. So not only just how to say it, but what do I do with it? I encourage my families to play emotional charades with their children on a regular basis so that everybody knows how to express and what to do with their emotions. The other thing I often teach people is how to use the and word. The and word can be very important because we can feel an emotion, like let's say that I'm angry, and I can choose an action, like I can go for a run or take a walk. Or I can feel sad and I can choose to cry or watch a sad movie. It's an action step. So sometimes teaching your child how to use the and word can be extremely helpful in helping them navigate their emotions. And then lastly, we want to really encourage you to continue to check in with your child. Don't leave them isolated. If they're not talking to you about it, like let's say that you addressed it once and then they're like, oh, okay, they must be fine because they're not bringing it back up. That may not be the case. So continue to check in on a regular basis with your child, at least once a week, just to see where they're at. And you're watching for some of the signs and symptoms of depression that can include a general hopelessness of the future. So if you find a child that just has no hope of the future or not interested in anything, then that's a warning sign that you want to probably get them in with a counselor. Another good warning sign is if your child does not find joy in any of their activities. That's a really big warning sign to say, hey, something's wrong and we need to get them evaluated. And then the last thing is if your child is having some big changes to their eating or sleeping patterns, like you have a child that's just not interested in food anymore and this lasts over several weeks, you want to take that seriously and get them evaluated. Now, I often hear in my practice, well, my child doesn't want to go to a counselor. Well, here's the thing, parents. Your child, if they're showing signs and symptoms, you should negotiate a deal. They should not have an option to not go and get evaluated, at least for the first 4 sessions. So in that first 4 sessions, you can negotiate with them to say, hey, I'm gonna require you to go to 4 sessions. And then after those 4 sessions, then you as a teenager can decide, yes, I want to continue counseling, or no, I don't. But at least you get them in for those 4 sessions. I hope that this has been helpful for you. If you find that you have a question, feel free to give one of our counselors.
Even before COVID-19 pandemic, youth suicide was already at a record high. Suicide is the second leading cause of death among people ages 10 to 24 and has been increasing every year since 2007. For the past 10 years, children and teens have been taking their own lives at alarming rates. It has increased nearly 60% between 2007 and 2018, according to the CDC.
Psychologists are still trying to pinpoint what bipolar disorder looks like in kids because the symptoms can manifest differently than they do in adults. It's very common for children to be misdiagnosed and treated for things like ADHD or generalized depression until symptoms inevitably get worse. Keep in mind that bipolar disorder is a progressive illness, which means it can get worse if it's not treated. If you have any questions after watching this video and would like to talk to me, I'd love to help. There's a link at the top of all my video descriptions where you can reach me directly. So let's go over a few of the typical signs and symptoms of bipolar disorder in kids. Please know that this is very generalized and everyone experiences bipolar disorder in their own unique way. Just because you show a few signs from this video does not mean that you have bipolar disorder. It just means it's worth taking a deeper look at. If you'd like to make a list of symptoms that you experience as you watch this video, that information could be invaluable to a doctor. So bipolar symptoms are divided into 2 primary groups, symptoms of mania and symptoms of depression. Kids who are experiencing bipolar disorder will typically cycle between the 2 major symptoms faster than most adults do. Let's start with several different signs of mania because that's where much of a bipolar diagnosis stems from. The first symptom, which I experienced as a kid, was getting hyper-focused on a single hobby, subject, or project. I'd become literally obsessed with something like a sport, class, or a game where it would interfere in other aspects of my life. I'd be sitting in class obsessing about a hobby or a game instead of listening to my teachers. This kind of hyper-focus would have been great if I directed it towards my studies, but my hobbies were much more stimulating. I was basically chasing the mania. My interests always surrounded something that released dopamine or endorphins. I wasn't in the chess club, I was doing karate or playing the most intense video game that I could find for hours on end. The second symptom would be acting hyper over-the-top happy or being silly in ways that aren't appropriate for that age. An example author Devin Fry gave was being unable to sit 10 minutes without dissolving into a fit of giggles. This caused me to be sent home a lot from school for disrupting class. The next common symptom is being highly imaginative, like coming up with intricate storylines for toys and acting them out with over-enthusiasm. This can even include dark or disturbing storylines for characters too. Many parents see this as just being a kid, but when it turns into obsessive play, really dark themes, or playing so enthusiastically that it disturbs others, it's worth paying attention to. If you take a toy away and it causes a total meltdown tantrum, that's not typical behavior, depending on the age, of course. Take away a toy from a 3-year-old and they're not going to be very happy with that. If it's a teenager, the reaction could be excessive. Also, if the child is playing with toys using sexual themes, especially in public, that's also worthy of examination. The fourth symptom includes rapid speech, where it's hard to understand what's even being said or switching topics suddenly without even noticing. When I was a kid, I'd literally give my parents indigestion at the dinner table because of how intense my communications were. I had teachers assume that I had ADHD when there was something much bigger going on. I couldn't sit through a movie, show, or a story without talking about totally off-topic things. So, moving on to the fifth symptom, hypersexuality is a symptom of bipolar disorder that many doctors fail to mention. Teenage hormones are so normal it's become a cliche, but if there's a preoccupation with sex, like talking about it at inappropriate times, acting on urges in public, engaging in risky sexual behavior, or even age-inappropriate behavior, there could be a problem. I have an entire video dedicated to hypersexuality if you'd like to learn more. Now for number 6. An embarrassing symptom I had as a kid was temper tantrums. I would get so angry I couldn't control myself and would exhaust myself throwing a tantrum. This was usually over simple things that normally wouldn't bother my brother at all, and that said a lot. It was really stressful on my little mind and body as a kid to experience such strong emotional responses like that. I know many people think of mania as this happy, feel-good state, but that isn't always true. Many people experience what's called dysphoric mania, or mixed states, where they can feel manic, but also crawling out of their skin with anxiety. This can majorly impact symptoms like unjustified temper tantrums. Sometimes not getting a toy the child wants is just a trigger or a reason the child believes is causing the underlying feelings of anxiety. It might not have so much to do with the toy at all and more to do with the child being symptomatic at the time. I would also get extremely upset when a small problem or disappointment would arise, much more so than the typical kid. I remember breaking down into tears over a simple homework assignment. I'd throw an over-the-top tantrum if I didn't get my way, or especially if it was something I was looking forward to. This wasn't me just being a bratty kid. The way I'd experience disappointment could physically exhaust me, and I'd be shaking for the rest of the day. It was enough to raise eyebrows with my parents. So the 8th sign of pediatric mania is a really big one, and I saved it for last. Sleep was a major issue for me as a kid. Trying to get me to take a nap was painful for my parents. I'd have a hard time falling asleep and would find any excuse to get out of bed. Lack of sleep can cause a bad crash and the cycle can just start over again. Sleep is probably one of the best metrics to gauge bipolar symptoms. A sudden change in sleep patterns can indicate that there's an episode starting. So all of the things I've mentioned so far help paint a picture of bipolar mania, but there's a lot more. I have entire videos dedicated to symptoms like mania and depression if you'd like to expand on these topics. Speaking of depression, let's jump into some of the common symptoms kids might display. First and foremost would be feeling sad for no apparent reason at all or being unusually weepy. Now, we're talking about teenagers here, but there's a difference between being upset because of a high school breakup or a bad grade and being unusually sad over things that typically wouldn't bother the average person that much. This is where the outside observation of friends and family are so important. When I'm symptomatic, the little things that trigger me seem illogical to others, but for me, it feels like it's the end of my world. The feelings are so damn real, it's scary. It was easy for my parents to dismiss my reactions because they simply couldn't relate to them. Having my feelings dismissed when they were so real was devastating in ways. If parents can look past the external behavior to see a child who's confused by their internal suffering, it helps to not take the behavior quite so personally. Moving on, the next sign of depression would be excessive sleep. If a teen is sleeping until past noon on a weekend, even with something fun planned that day, something isn't right. Using a phone app or a journal to document sleep and mood patterns over time can be such valuable information. I can't stress that enough. The third sign of depression would be a sudden change in appetite. Extreme eating habits like eating too much or losing weight quickly from not eating enough are important signs to watch for with bipolar disorder. Some people turn to food as a comfort when they get depressed, causing them to gain weight. Others might lose interest in food holistically while depressed, so it's important to take note of any sudden change in weight or appetite. Moving on to number 4. It's amazing how much depression can manifest physically in people. Kids might complain of frequent headaches, stomach aches, or even miss school from the emotional stress of symptoms. Stomach ulcers at a young age can also be part of this. If your kid keeps getting sick while no one else in the family does, it's worth taking a closer look at that. Number 5 is a big one, and this would be a sudden loss of interest in activities that we usually love. I was very passionate about my hobbies and socializing when I was a kid. If I'd get depressed, I'd lose interest in all of that. I wouldn't want to go to karate class, or I'd cancel socializing with a best friend. This was very unusual for me, and my parents would always ask me what was wrong. It was hard for me to describe something I didn't understand myself, so my reasons often didn't make sense to my parents. I have an amazing video titled "What's Wrong with What's Wrong" if you'd like some tips on approaching someone when they're obviously suffering. The last symptom I want to talk about is a life and death thing. It doesn't get more serious than this. I've mentioned in other videos how 1 in 5 people with bipolar disorder take their own lives. I've lost several friends in high school because of suicide, and every single one of them appeared to be just fine externally. It was always a massive surprise when we'd lose someone. Sometimes parents forget how nasty it is to be in high school or elementary school. A big wake-up call for my parents was when I went on a walk with my mom one day and I kept saying things like, "I wish I wasn't born," "I'm a bad person," "People hate me," "I'll never succeed at anything in life." Things like that aren't typical things that a happy kid is going to say.
You may also observe differential diagnosis. What does this mean? It is a method of analysis of a patient's history and physical examination to arrive at the correct diagnosis. And it involves distinguishing a particular disease or condition from others that present with similar clinical features. So some of these may include normal reactive feelings of sadness, ADHD, other medical disorders, adverse drug reactions, substance abuse, and psychosis. You also may see warning signs of suicidal behavior. Short term means thoughts of suicide as a solution to a problem. Other warning signs for suicidal behavior include recent losses, hopelessness, isolation, and lack of the opportunity to confide in a friend. Social disadvantages would include broken home, unwanted pregnancy, conflict with family or parents, and sexually abused girls are 20 times more likely, and sexually abused boys are 40 times more likely to commit suicide. Be sure that you encourage children to avoid alcohol, illegal drugs, unnecessary pressures, and parents should avoid self blame, exhaustion, and other psychological causes of hunting.
Hospital. Today we're going to be talking about ADHD. One of the first questions I get asked is ADHD overdiagnosed? I think it's a hard question to answer, and the most important thing is to go to somebody you trust for the diagnosis. There really are standards. The main one is that ADHD affects all kinds of different aspects of their life. So things like rating scales should be taking place at school, potentially sports, and definitely at home. A lot of parents are hoping to avoid medication, and medication is a very personal decision for every family. There are some things that you can try before pursuing medication. Some of these include avoiding dyes, changing diet, and addressing sleep. If these are things that you can easily do as a family, I recommend trying them. But it's really important that we think about your child's overall functioning. For some children, it doesn't matter how many of those changes we make, they're still going to have trouble at school or at home or socially. In those cases, it really matters to talk to someone, again, that you trust. A lot of pediatricians feel comfortable handling the initial diagnosis of ADHD. If you have additional concerns, there are people like me who do more complicated cases or can answer additional questions. We have a collaborative care clinic at Children's Hospital that works with pediatricians to help them take care of their patients, especially with mental health issues like ADHD. Sometimes girls are actually diagnosed later or not diagnosed at all, especially if they have the inattentive type. Rather than disrupting the class, they tend to lose information. Historically, ADHD has actually been more commonly diagnosed in boys, largely because they often present with disruptive behaviors that are easy to pick up in a classroom. We have to be careful, actually, that we don't miss boys who have the inattentive type. That's more of the daydreamer or ones who are just missing content because they're focused on something else. So what we usually see is a child who's been doing well, but suddenly hits a grade where it doesn't seem like things work anymore. It's really important to get the schools involved early and get assessments done, because sometimes it's a matter of attention. I like to think of it as somebody else holding a remote when you watch TV. This means that every couple of minutes they change the channel and you're always catching up, trying to figure out what happened last time. When the content's easy, you can do that. But as you go up in the grades, sometimes you start having big knowledge gaps that then affect how you do academically. One of the things that can complicate making the diagnosis of ADHD is a lot of things affect attention. I like to think of this as a busy intersection. So depression actually can lead to inattention. Anxiety can actually lead to over-focus or difficulty with distractibility, and several other conditions, including learning disorders, can be both common in patients with ADHD and can be misdiagnosed. If you decide to do medication, I want you to know that these medicines have been used for over 50 years, and when used by skilled people, they can be very safe and very effective. The goal is to get on the smallest amount of dose, but still meaningfully impact how they do at school or socially. This is a great time to have a team. Take any of your questions to your pediatrician. If you're worried about your kid paying attention, being hyper, or just doing things without thinking, that's a great place to start.
My daughter was always playful, but at 8 she started saying she had stomach aches before going to church and school. She was so worried about talking to people.
A friend of my son attempted suicide. They're only 15 years old. I'm so worried about them.
Our babysitter was great, and we considered her part of our family, but she stopped returning our phone calls and texts. Her mom said she'd been closing her door at home and sleeping all the time.
My son got in trouble at school for picking on people at gym class and was caught with alcohol in his car. He seemed so angry all the time.
These are the voices of adults who are worried about youth with symptoms of depression or anxiety. Depression and anxiety are the most common mental health symptoms in young people and can have a significant impact on their relationships, on what they do, and how they feel. Parents, teachers, coaches, group leaders, and other adults should keep a few things in mind when supporting young people who are struggling. Mental health problems are common. Young people who experience mental health problems often feel like they are alone and worry that people won't understand how they feel. They can be surprised and relieved to find out how many other people have experienced something similar. Pay attention to behavior. Children and adolescents don't always have the words to explain what they are thinking or how they are feeling. Paying attention to their behavior is important. Withdrawing from friends and family, frequent illness, too much or too little sleep, irritability, disciplinary problems, or substance use at a young age can be signs that they are struggling with depression or anxiety. It's okay to talk about it. Parents and other adults who speak confidently and openly with youth can make a big difference. Asking calm, non-judgmental questions is often a critical first step toward helping a young person who is struggling. Sometimes it's temporary. While anxiety or depression might be uncomfortable and cause problems, and a person might need extra support, it's common for people to experience only a single episode or have a symptom that gets better and doesn't come back. Treatment works. Whether a young person experiences a single episode of depression or anxiety, or it is a longer-term struggle, it's important to remember that both depression and anxiety can be treated. Sometimes treatment happens only with the young person, and sometimes the family is involved. Either way, depression and anxiety are treatable conditions. Use crisis services when needed. If young people experience a mental health crisis, such as thinking about or talking about suicide, making a suicide attempt, hurting themselves, or using dangerous amounts of alcohol or drugs, don't hesitate to go to the emergency room. Call 911 or contact the National Suicide Prevention Lifeline at 1-800-273-TALK. Each of these resources has professionals trained in managing a crisis situation. Depression and anxiety are common among children and adolescents. With just a little bit of knowledge and preparation, parents, families, teachers, and other adults can be confident, understanding, attentive, and supportive of those who are struggling.
Psychopharmacology is the field of study within biological psychology that examines the relationships between psychological functioning and behaviors and drugs. Psychopharmacologists develop all therapeutic drugs, as well as study the effects of drug addiction and dependency. Drugs that have psychological impacts tend to fall into one of three categories. Some drugs are agonists, which means that they increase the effects of a particular neurotransmitter system, such as dopamine. For example, a dopamine agonist increases the activity of dopamine in the brain. A serotonin agonist would increase the activity of serotonin in the brain. An antagonist, on the other hand, decreases the effects of a neurotransmitter, so that an acetylcholine antagonist would be a drug that decreases the effects of acetylcholine in the brain. The third and final main effect that drugs could have would be to have a modulatory effect on a neurotransmitter, which means that it modifies how that neurotransmitter system is functioning. For example, making it more or less sensitive. A specific drug can cause more than one effect in different neurotransmitter systems. For example, the same drug could be a dopamine agonist and an acetylcholine antagonist at the same time. In fact, the effects of most drugs are rather complicated and therefore the source of side effects. In summary then, psychopharmacology is the study of the complex relationships between drugs and psychological functioning and behavior.
There are also different psychosocial therapies in which clients can participate in, including interpersonal, analytic, play, behavioral, family, and school-based.
Welcome to Treatment of Addictions Psychosocial Interventions. In this module, we will learn that there are important psychosocial factors that can influence the development, maintenance, and treatment of addictions. The recognition of psychosocial factors in the development and treatment of addictions is not a recent event. In 1804, Thomas Trotter recommended that physicians and patients should meet regularly to formulate and implement a sobriety plan. The treatment of drunkenness was a disease of the mind. Several inebriety asylums were created in the 19th century as addictions started to be seen as a medical problem. But as we realized how challenging the treatment of addictions was, other treatment options were developed. Some of these treatment options were not developed by the medical profession, but by the patients themselves. In 1935, Bill Wilson and Bob Smith founded Alcoholics Anonymous. And 2 decades later, Charles Dedrich founded the first therapeutic community. These are 2 major and lasting contributions that we will cover in this module. We will also look at specific individualized interventions, such as cognitive behavior therapy. And we will understand the importance of family members in the treatment of addictions. We will also learn about interventions specifically designed to treat addictions, such as relapse prevention, motivational interviewing, and contingency management. Many of these interventions proved to be effective and were later applied to treat other psychiatric and health conditions. Another intervention that has gained much attention in the treatment of addictions is mindfulness. This is a dynamic field, and we will make sure the module is updated with the latest treatment options. During this module, you will discover several interesting approaches and understand their theoretical underpinnings and clinical applications. Most importantly, you will understand the evidence-based supporting the effectiveness of these treatment options.
The term psychosocial health is frequently used today. But do we actually know what it means? Let's explore the life of Marie for a few minutes. Marie's character is shaped by her experiences, her perception, her thoughts, her feelings, her behavior, and her lifestyle. Marie also exists in a social environment. It is an environment that consists of her close social contacts, like her family, friends, colleagues, and neighbors. But Marie also lives within a broader social context. This can include society as a whole or a particular cultural environment, something that can vary according to the country in which she lives. Psychosocial health is a product of this interactive relationship that Marie shares with her social environment. The term describes a state that is constantly changing. Psychosocial health can also be strengthened or weakened by a number of influences. Such influences can be both personal abilities, like the development of relationships, as well as physical qualities, like a disability or disease. The distribution of material goods, social inequalities, workplace stress, and religious spiritual beliefs can affect our psychosocial health as well. Let's now imagine that a traumatic event has occurred in Marie's life. Her brother has died. She feels the effect of this loss both mentally and physically. Marie mourns her brother and is unable to work for a temporary period of time as a result. She also loses her appetite and feels depressed. Depending on Marie's age, her mourning could also negatively affect her performance in school, her professional future, or her relationship with her close social contacts. But during this difficult period of time, Marie is comforted and consoled by her family and friends. This helps her deal with the situation and come to terms with it. If you take all this into account, the expression can be defined this way. Psychosocial health is an alternating condition that involves the reciprocal adjustment and dependency between an individual and his or her social environment.
What happened to Bernice? Has she found a way to manage her depression? Is she still racked with anxiety? Well, it's really nice of you to ask, and I'll tell her you said hi. But for our purposes, as students of psychology, the bigger question arising from Bernice's case is, has psychotherapy helped? And just as important, how can we tell? Well, believe it or not, one of the main ways experts use is to simply ask the client and see how they say they're doing. Is Bernice out of bed and living her life? Did she make it through midterms without spiraling into a crisis? And did she take that plane trip to Baja to party with her girls? As a clinician, that would all be useful to know, right? But the key is that we want to ask these questions in a scientifically rigorous manner so that we really know a treatment works, rather than just extrapolating from individual cases. And there's also a whole other category of treatment that's pretty different from the talking and listening that goes on in psychotherapy. These are as much medical intervention as they are psychological science, the biomedical treatments. These can be as commonplace as medications like Zoloft or lithium, or a bit more unusual and invasive like magnetic stimulation, neural implants, or even electroshock therapy. And yes, it's still a thing. Healing a troublesome mind isn't like healing a broken arm. So one of the challenges that psychologists face is simply knowing whether they're doing their job and doing it well. The methods psychologists use to assess how effective treatments are mostly involve client and clinician perceptions, along with outcome research. Client perceptions are just what they sound like. You see a therapist and someone asks you how you feel after your treatment. It varies by treatment, but client perception tends to be pretty rosy. One study found that 89% of folks said that they were at least fairly well satisfied with their treatment. But of course, perceptions are inherently subjective, and some believe that the therapeutic relationship lends itself to a positive bias in client reviews. Basically, if you're sticking to your treatment, you probably like your therapist. Clinician perspectives can be similarly skewed, not only in terms of a self-serving bias, but also because they may not be around to see a client's future relapses or setbacks in mental health. A patient could see 10 therapists over time, feel better at the end of each treatment, but keep struggling over the long term, even though each therapist thought the treatment was a success. So, can we objectively measure how well psychotherapy works? Well, we have treatment outcome research, a way of systematically measuring which therapies work best for which problems. And the gold standard of treatment outcome research is the randomized clinical trial, or RCT. If you'll remember your research methods, you'll know that RCTs generally require randomly selected assigned participants, a control group, and at least one experimental group that receives the treatment. This design accounts for individual differences between people and other extraneous factors so that we know that if people in the experimental group get better and people in the control group don't, it was truly the therapeutic intervention that made the difference. And once enough researchers have run their own RCTs, you can gather data via meta-analysis, measuring results across multiple trials to see basically whether a treatment works and how well it does across a variety of settings. Two important terms you should know here are effectiveness and efficacy. Effectiveness is whether or not a given therapy works in a real-world setting, whereas efficacy is whether a therapy works better than some other comparable intervention or a control. Both terms matter, and you'll want to get them straight if you're trying to parse the research literature. Dozens of studies have confirmed that psychotherapy is both effective and efficacious. While controls, usually people who don't get any therapy, often do get better on their own, those in psychotherapy usually improve faster and with a significantly lower risk of relapse. However, And try not to look too shocked when I tell you this, there is a lot of argument about which therapies work best. In some cases, like phobias, there are clear winners, behavior therapy for instance. In others, like major depressive disorder, there are cognitive, behavioral, and psychodynamic interventions that have all been successful in RCTs. And while a lot of psychologists seem to get a kick out of arguing about which therapies are better than others, there do seem to be some common factors that unite the more effective ones. A big one is simply instilling hope, helping demoralized clients regain hope that things can and will get better. There's also the value of getting a new perspective, learning that there's a plausible explanation for your troubles and finding a new way of looking at yourself, the world around you, and what your future might look like. And across the board, any good therapist provides genuine empathy within a trusting, caring relationship. They seek to listen and understand and not judge, and offer clear and positive communication. But psychotherapy, or talking it out, is just one way to treat psychological disorders. Quite often, biomedical therapies are an option, sometimes for the more severe disorders, but in many cases, in combination with psychotherapy. Biomedical therapies aim to physiologically change the brain's electrochemical state with psychotropic drugs, magnetic impulses, or even electrical currents in surgery. As you might expect, pharmacotherapy is by far the most widely used. That's the one where you just take drugs. Psychotropic drugs are just any pharmaceutical that affects your mental state, and the most commonly used ones fall into four major categories: antipsychotics, anxiolytics, antidepressants, and mood stabilizers, each aimed at a specific family of problems. Antipsychotics are used to treat schizophrenia and other types of severe thought disorders. Most of these medications alter the effects of the neurotransmitter dopamine in the brain by blocking its receptor sites and blocking its uptake. This is based on the assumption that an overactive dopamine system contributes to schizophrenia, but like many psychotropic drugs, antipsychotics come with nasty side effects. Anxiolytics, or anti-anxiety meds, usually work by depressing activity in the central nervous system, much like a stiff drink might. For this reason, and others, it can be super dangerous to mix certain anxiety meds with booze. Also, letting your nerves mellow out can feel so good that patients may risk becoming addicted to some anxiolytics. Antidepressants are used to treat depression, as you might expect, but also a number of anxiety disorders. Each type is thought to work a bit differently, mainly by altering the availability of various neurotransmitters like serotonin and norepinephrine in the brain, which in turn appears to help with mood and anxiety problems. Some of the most common are selective serotonin reuptake inhibitors, or SSRIs, like Zoloft, Paxil, and Prozac, which partially block the normal reuptake of serotonin. This makes it more available to the synapses, which, hypothetically at least, allows its mood-enhancing effects to kick in. Current research suggests that the use of antidepressant medication is most effective when combined with psychotherapy, which makes a lot of sense, and the same goes for a number of other psychological disorders. It's worth pointing out here that some meta-analyses suggest that antidepressants aren't any more effective than psychotherapy when symptoms are mild to moderate. One meta-analysis that riled people up in recent years even suggested that antidepressants are no better than a placebo in those cases. So psychotropic drugs can help, but sometimes you also need to start exploring the root causes of your issues and reevaluate how you deal with them, which is what psychotherapy is perfect for. Bernice, for example, probably would have benefited from both talk therapy and a dose of anxiolytic or antidepressant meds. The last big psychotropic drug group is the mood stabilizers. They can be extremely effective in smoothing out the highs and lows of bipolar disorder. Simple salts of lithium were the first of these drugs used, and they remain in widespread use today. Dr. K. Redfield Jamison, who we talked about a few weeks ago, has said that lithium prevents my disastrous highs, diminishes my depressions, gentles me out, keeps me from ruining my career and relationships, keeps me out of the hospital and alive. And while drugs are the most popular biomedical treatment, they aren't the only kind. For one, there's electroshock therapy. Now, hear me out. This does carry a long history of negative connotations, like of people being strapped down and shocked into mental oblivion, but the technology has made a comeback and can actually be quite effective in treating severe treatment-resistant depression. It's properly called electroconvulsive therapy, or ECT, and it involves sending a brief electrical current through the brain of an anesthetized patient. This excites the neurons, causing them to fire rapidly until the patient goes through a small, controlled seizure that lasts about 2 minutes. And we're not exactly sure why this helps relieve negative symptoms, but there are several theories that are being pursued. One suggests that the resulting seizure beneficially alters neurotransmitter activity in areas of the brain associated with moods and emotions, effectively jump-starting a severely depressed brain. Another theory suggests that these electrical impulses modify stress hormone activity in the brain, which we know could play a role in sleep, energy, appetite, and mood. ECT may also reactivate previously dormant or suppressed neurons, or possibly stimulate the growth of new ones symptoms in key brain regions, helping the brain regain some level of lost functioning. There are a couple of other brain stimulation treatments too that are more gentle. One is repetitive transcranial magnetic stimulation, RTMS, which involves the painless application of repeated electromagnetic pulses. Another, deep brain stimulation, DBS, is more invasive and calls for surgically implanting a kind of brain pacemaker that sends out electrical impulses to specific parts of the brain. Despite all the new research and often positive results around RTMS and DBS, we're still sorting out how these treatments work to heal the brain and mind, but they're hypothesized to jumpstart the neural circuitry in a depressed brain similarly to ECT. So you'll notice that all these options come with certain risks, and really no treatment is entirely risk-free, perhaps not even psychotherapy. But we should also note that some of the less severe manifestations of psychological disorder may be improved with pretty simple lifestyle changes. 30 to 60 minutes of daily aerobic exercise has been shown to be as effective as antidepressant medications in research on mild depression. Just remember those words, daily and aerobic. Adequate sleep, social interaction, and good nutrition also all play a part in managing moods. In other words, general healthy living helps. There's an old English proverb that says different sores have different salves, and the same is true here. What works for one person may not work for another, and sometimes a few different kinds of intervention might be needed all at once. Today, you learned how client and